we're going to talk about a few of the drugs that are listed in Module 4, drugs that deal with alterations in digestion. In the beginning of Module 4, your text in Pearson talks about emesis, nausea, vomiting. There's talks about, like, page 220, 221, alterations and therapies, nausea, vomiting, GERD, hepatitis, malabsorption, pancreatitis, pyloric stenosis. So we're going to touch briefly on a few of the meds for the nausea, vomiting, and then cover hepatitis. There's really no meds in your malabsorption. And we'll do pancreatitis. Pyloric stenosis, I think, was covered in peds. It's not covered in this module for your med surg. So when you look at your nausea, vomiting on page 220, that's your assessment things, and some things you can do outside of medications, such as small quantities of clear liquids and dry foods, maybe keeping them NPO, bland foods once the nausea has subsided. So page 231 in your Pearson text has a list of several antiemetics, but we're just going to focus on a couple of them. First one we're going to focus on is hydroxyzine or Visceral. As you can see, the class is an H1 antagonist. As you know, the H1 antagonist, H2 is what we talk about, the H2 blockers or H2 antagonists for your nausea. It has to do with the place in the brain where this takes effect. Hydroxyzine is, or Visceral, Atarax, you may have heard it. It's also it's an anti-anxiolytic. It's an anticholinergic because it affects your histamine receptors. It's also an antihistamine. It has some analgesic effects. It causes smooth muscle relaxation. And among these things, it also controls nausea and vomiting, so it has multiple uses. Our use that we're focusing on here will be as an antiemetic. Caution in the very young and very old because of the other classes for anticholinergic, antihistamine, analgesic. It increases CNS depression, which is not surprising considering all the therapeutic effects. Anticholinergic effect is your dry mouth. Your CNS depression will cause your drowsiness. There is more information on hydroxyzine in your drug handbook that starts on page 578. So where should you focus in your drug handbook? Let's see. One of the things in the beginning, it tells you not to get confused between hydroxyzine and hydralazine, which it's easy to mix those two words. Okay, your uses, again, we're focusing on the antiemetic. Under your precautions, look at your cautions. Remember, anticholinergic effect, so the narrow angle glaucoma, prosthetic hypertrophy, that's with any bladder, neck obstruction, asthma, COPD, elderly are cautions because of the anticholinergic effects. Your action, I talked already about it, blocking your histamine receptor. You see your route is by mouth, is oral, it comes in a liquid or pill form. Lifespan considerations in children, it can have an opposite effect of paradoxical excitement in your elderly because of the CNS depression and slower, longer half-life, slower excretion. They may have an increased risk for dizziness and falls. They may have hypotension. They also, just like children, may have hyperexcitability. On your interactions, look at your drug interaction, anything that just suppresses the CNS, such as alcohol, benzos, will have an aggravated effect. There's some herbal interactions with kava and St. John's wort. Over to no dose adjustment for renal hepatic. Your side effects, look at your frequent, which is your drowsiness, dry mouth, which I also mentioned. Don't worry about doing the IM thing. Your nursing considerations when you look at your baseline assessment on your antiemetics, just like you should for anybody with nausea, vomiting, GI issues, assessing for dehydration, and your interventions evaluations go all the way down. Assist with ambulation if drowsiness, lightheadedness, obtain EKG if they have palpitations because they may have some arrhythmias or irregular rhythms. On your last page, on page 580, just down to avoiding tasks that require alertness. And again, this is your patient teaching about any chest pain or pressure because of arrhythmias. The next one we're going to cover is your, I can always never say this, prochlorperazine. I always call it compazine because I have trouble with that one. That on page 231 of your Pearson is a dopamine agonist. That's the only one of these I want you to focus on. It's interesting if you look, I don't know if you'll remember it, the phenothiazines for mental health, because it is a class of an antiemetic and a phenothiazine, which is one of the first, what do you call it? One of the older first classes of your antipsychotics that have major EPS problems. Okay, so its use is for severe nausea and vomiting. I listed your contraindications, cautions, nursing considerations. They're in your drug handbook. When you're going through here, what should you be aware of? So it starts on page 967. Use severe nausea and vomiting, which I said I try to pull out your key things onto the slide, but I will help you focus more here on precautions. Not so much coma for your use, but presence of large amounts of CNS depressants such as alcohol or opioids. Now, you'll be given this for severe nausea and vomiting. In this section, we're talking about digestive issues, major digestive issues. So if you've got like a pancreatitis, you'll have a lot of problems with nausea and vomiting. So you may be on major pain medications. So you'll have to be cautious with the interaction because of CNS depression. Further down under cautions, history of seizures and Parkinson's. Be careful with renal hepatic impairment. It also has some anticholinergic effects. So you're looking at the urinary retention, BPH, narrow angle glaucoma, if paralytic ileus, if the gut is not working. Centrally acting, your action, it affects, blocks the dopamine. So that's why there's a problem with people with Parkinson's being a real caution, because the Parkinson, it will aggravate the Parkinson symptoms, why you may have these under caution, your EPS or extrapyramidal symptoms. It has a long half-life, lifespan considerations on elderly, more susceptible to orthostatic hypotension and the anticholinergic effects, can't eat, can't see, can't pee, dry mouth. Interactions, any central nervous system depressant such as an opioid or benzodiazepine. It has your bowl there, your extrapyramidal, the problems because of that blocking your dopamine, so your Parkinson-like syndromes. And if you give it with other drugs like Haldol and metoclopramide, which we're going to talk about metoclopramide in a minute, those two drugs also have that potential effect. So bringing those two together, there's great risk of having these EPS symptoms. Go down to your herbal, Don Kai, St. John's wort, Kava. Those are three to keep in mind. And the availability, it's given in every route, IV, IM, PO, and rectal. It can cause dermatitis, irritation if it gets on the skin, and so be careful with IM injections. You want to do it deep. Go over on 968 to your side effects. Just look at your frequent, which you, again, if you think of your Anticholinergic, CNS depression, your drowsiness, hypotension, dizziness. And they said fainting, which is common just on the first dose, not so much after that. Adverse effects, I talked about the EPS. You may want to read through part of that section, reminding yourself about the EPS, the akathisia, which is the tapping of the fingers and hand movement, Parkinson-like syndromes, the tremors, the shuffling, muscle spasms, dystonic reactions such as diaphoresis and pallor, and your tardive dyskinesia, which is your tongue protrusion, puffing of cheeks, and puckering of the mouth. Over 569, under nurse considerations, just go to antiemetic, which we already talked about. If somebody is nausea or vomiting, you're assessing for dehydration. Interventions, evaluations, your fine tongue movement. I would not worry here on blood dyscrasias because we're not talking so much about keeping this on a chronic basis. Your blood dyscrasias would be more on a chronic basis, like if you were given it for a psychosis, but any time increased suicidal risk is something to look for. Your patient family teaching, avoiding tasks that require alertness and motor skills. That would be all on this drug. Your next one, metoclopramide. So your metoclopramide is listed in your Pearson text on page 231 under your dopamine agonist. Being a dopamine agonist is going to have a lot of the same things as we just talked about with your prochlorperazine. It is an antiemetic that increases gastric motility. Not for long-term use. I may have mentioned in the past that it's not used like it used to be because of the complications. So if you go in your drug handbook on page 761, the main use here, it says for oral asymptomatic treatment of diabetic gastroparesis or for GERD and we're looking at it for nausea and vomiting. It does stimulate gastric motility, so it would help with nausea and vomiting to move things through the gut. Another thing it could be used for is for, especially in the elderly, if you're dealing with a gut, you have to put in like a feeding tube, some kind of gastric tube for feedings, and it can help that motility to get the tube to move down further. So precautions on page 762, look at your contraindications, of course, concurrent use with other drugs that increase extrapyramidal activity or EPS, such as I mentioned with your compazine. And if it's somebody that's on a phenothiazine, such as Haldol. Okay, also contraindicated if GI motility may be dangerous. When would that be? That's with somebody with a possible obstruction, especially if they do have obstruction or paralytic ileus where the gut is not moving. If you don't want things to go through the gut for any reason, this is contraindicated. Under your action of blocking your dopamine, it's in that class. That's why the extrapyramidal is a problem. It can be given by mouth, IV, or IM, depending on the reason for it. Go down to lifespan considerations, and the elderly are more likely to have these Parkinson symptoms after long-term therapy. But I know the latest research is saying even 3 days of use can have these extrapyramidal symptoms occur, especially in the elderly that have a slower metabolism and excreting this medication. So if it's used, they try to do a one-time dose for whatever they need it for now. Drug interactions on the bottom of 762, just look at your CNS depressants and anticholinergics. There's no herbal thing. Skip all the way over to page 763 in your drug handbook. Go to your side effects. Your frequent are your drowsiness, restlessness, fatigue, and lethargy. Adverse effects, again, your EPS symptoms. On page 763, your nursing considerations, the same thing, looking at dehydration. Assess for nausea, vomiting. Remember here, abdominal distension, and always assessing bowel sounds when you're given metoclopramide, because you need to know immediately if there's an obstruction. This drug has a half-life that is, what, 8 hours? 4 to 6 hours, which is pretty long. So you need to know. What else? Patient family IV administration is more likely to have these EPS symptoms. Patient family teaching, the last part, report involuntary eye, face, limb movement, and avoiding any alcohol because of the CNS depression. That is all you need to know on your antiemetic drugs. Now we're going to go into the drugs for management of hepatitis. So hepatitis in Pearson is exemplar 4B. On page 247 of Pearson, it touches briefly on treating type A and B. We're only going to focus on interferon alpha. Page 248 of Pearson goes over your immunizations, post-exposure prophylaxis, and interferon alpha. Do want to touch on here, there is vaccines to prevent hepatitis A and hepatitis B. There's even a combination AB. A was not something we normally worried about in the United States. Unfortunately, it is becoming a problem, so some areas are vaccinating for Hep A. Post-exposure prophylaxis, that's where you give immunoglobulin. Immunoglobulin is giving them the actual antibodies. So that's for immediate exposure when somebody may not be protected from that thing. So you have, your body gets exposed to these proteins, antigens, and it forms antibodies. So if they don't have these antibodies, you give the immunoglobulin. Immunoglobulin being antibodies can cause an anaphylactic reaction. Okay, just wanted to touch on that again. So here on page 248, your interferon alpha. There are multiple types of your alphas. Just focus, like I did on your slide. Interferon interferes with viral replication. They're produced by the human leukocytes, a type of white blood cell. Short half-life and required administration several times per week. And I'm going to talk about that in a minute. We have these PEG interferons that they develop. So instead of giving it 3 and 4 times a week, these PEG interferons are longer acting, increased half-life, so they can be administered once a week. All of these, the alpha 2A, alpha 2B, and the PEG interferon alpha 2A and PEG interferon alpha 2B are administered IM or sub-Q, often sub-Q because they learn to do self-administrations at home. So in your text on 248, it does say administer by subcutaneous injection, monitor for manifestations of hypersensitivity, bronchoconstrictions, and angioedema. Have emergency equipment available, monitor complete CBC, platelet count, and renal and liver function, assess your mental status. Education may cause flu-like symptoms with fever, fatigue, body aches, headache, and chills that diminish over time. So that is very important in your teaching that they understand that. Because again, I said you will teach them to inject these at home. So the only difference is your alpha 2A or alpha 2B that is given several times a week versus your PEG interferon alpha 2A, PEG interferon alpha 2B, which is about once a week. So look over your nursing considerations in your interferon alpha. We're going to move into your drugs for the management of pancreatitis. Your pancreatitis in Pearson is module 4D. There's not very much in 4D as far as pharmacology. If you go back to page 221 in the introduction to this concept, module 4, It does talk about pancreatitis, acute pancreatitis, opioid analgesics, and chronic pancreatitis, again, opioid analgesics, and giving some pancreatic enzymes, and using some H2 blockers. So keeping the patient NPO to decrease pancreatic secretions, giving opioid analgesics for acute or chronic for pain management because it is very painful. Because of the issues, you're going to give fluid replacements, and you may have to give prophylactic antibiotics. I'm not going to go into antibiotics for this section or for this test. So opioid analgesics, we'll cover some things on them now. When we get into back pain, we'll get into analgesics again. So that's something that we will repeat. So opioid analgesics, I made it list here in the order of, I guess you can call strength or potency. Started with your hydrocodone, it gets stronger with oxycodone, then your morphine, hydromorphone or Dilaudid, and then your fentanyl. Your hydrocodone, all of these are listed in your drug handbook, but I'm going to give you what you really need to know because we'll get deeper probably into these when we get into back pain, muscle pain. So your hydrocodone is listed in your drug handbook on page 571. It is for the management of acute pain, sometimes in combination with Tylenol, acetaminophen, or ibuprofen. That's when you'll see, like listed on this picture, where are the hydrocodone, your Lortab, Vicodin, Vicoprofen. Your Lortab and your Vicodin are your hydrocodone combined with acetaminophen. Your Vicoprofen, anytime it ends in this profen, that is when your hydrocodone is combined with an ibuprofen. I tell you this because of education. When somebody's on a hydrocodone, whether it's Lortab, Vicodin, any of those, that you need to educate them and not taking over-the-counter aspirin, ibuprofen, Tylenol, acetaminophen, depending on which one these on, because of the max dose in 24 hours. It is for moderate acute pain, supposed to be, but they've been used for chronic pain. They were actually, I think your drug handbook still has them as a class 3, a schedule 3. They have been moved to a schedule 2, not due to potency, but to addiction and overuse. So they've now become a higher schedule where people can only get 30 days prescription at a time, and it has to be a written script, because it was supposed to be for acute pain. Let's see. Your oxycodone is in your drug handbook on page 886. It's for moderate to severe pain. They do make, looking for your oxycodones here. Percocet, Percodan are both oxycodone. Percocet is oxycodone with acetaminophen, CET in it. Your oxycodone, your Percodan, is your oxycodone with aspirin. Your Oxycontin is a slow release form of oxycodone. When you see Oxycontin, you do not crush, do not break up, because it is a slow release form. So breaking, chewing, splitting can cause an immediate overdose because it's a very potent, slow release extended form. Then you have your morphine, which is not on this picture. On your next slide, I talk more about morphine and adverse effects, because the way you deal with opioids, they talk about morphine derivatives. So your hydromorphone and fentanyl, which are very, 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 very potent forms when you talk about morphine derivatives. Just know your morphine is on page 794. MS-Contin is a slow release form of morphine. Again, the same precautions as your Oxycontin because the slow release. your hydromorphone, which you will probably have heard more dilaudid than hydromorphone. That's what it is. It's on page 575 of your drug handbook. It is 5 to 10 times as potent as morphine. It's for the management of moderate to severe, acute, and severe chronic pain. So you will see that used in a lot of the things with the like acute pancreatitis and chronic pancreatitis. It is very, very addictive, high risk for abuse. Because of its potency, very high risk for overdose. It is supposed to be prescribed when other measures have failed. Your fentanyl is listed on page 491 of your drug handbook. It is 100 times as potent as your morphine. It's very, very potent. It comes in, it is not in an oral form. It is only in a patch or injection form. It's only one of these that doesn't come in an oral form. So here I found a really good mnemonic for what you're looking for adverse effects or potency, problems, risks. That will be with all of these, with your morphine, hydromorphone, fentanyl, mostly. So I thought that was really good. It's spelling out your morphine with your meiosis or pinpoint pupils. Any of your opioids will cause pinpoint pupils. Orthostatic hypotension, the more potent the opioid, the more risk. I said all opioids are listed by morphine derivatives. So this was a perfect mnemonic for opioids. Respiratory depression, physical dependency, histamine release. That's where you're looking for possible allergic reaction on your opioids. Your increased intracranial pressure, nausea, euphoria, and sedation. Now, the only other drug we're going to cover for pancreatitis is your pancreolipase or pancrease, which is for your chronic pancreatitis patient. This is mentioned in your Pearson on page 26. Oh, I wrote 264 on your text. Yeah, it is 264. It's actually also on page 265. It is not listed in your drug handbook, so don't worry about going there. I gave you what you need. It's a combination of 3 enzymes, your lipase, protease, and amylase, which is normally produced by your pancreas, but your pancreas is dysfunctional, especially chronic pancreatitis, so you have to replace those. Side effects: abdominal pain, diarrhea, greasy stools, abdominal discomfort, skin rash. Given with meals or snacks. It is not given in between. It's taken when the food is taken. It's not 5 minutes before, 5 minutes after. It's given when the meal is taken because you need this enzyme to do the digestion. I said it's used for chronic pancreatitis, helping to treat their malnutrition and malabsorption. It must be stored in a cool, dry place. They have, it's weird, it does, if you look it up, antacids decrease the absorption and effectiveness, but at the same time, the pancreolipase can be so irritating to the stomach that they say to give it with an H2 blocker or possibly a PPI, maybe even an antacid, but you're better off using an H2 blocker, getting the enteric-coated form of this, or using a PPI rather than an antacid, because the antacid will coat the stomach. So, what else? Pancreolipase needs a pH greater than 5.5 for absorption. So when you're lowering the pH by blocking those acids, it's difficult to absorb. So it's delayed release capsules that are enteric-coated are the best to give, because then you're not worrying about the pH in the stomach and the irritation. They do have capsules that have granules in them. If you have to sprinkle it onto the food, if they cannot swallow, to help with the absorption there in their food. Again, thinking of of the pH of the foods. The sprinkles can cause irritation on the lips and the oral mucosa. I'm just all for the coated one to avoid so many of these problems with it. Next here on page 265 in Pearson Health Education, take with meals or snacks. If it's enteric coated, do not crush, chew, or mix with alkaline foods such as milk and ice cream. Be sure to follow prescribed diet. Continue taking this drug until unless told not to. Okay, so we're going to move into here in a little bit covering your total parenteral nutrition. Total parenteral nutrition is given IV through a central line. It may be a peripherally inserted line, a PICC line, or a centrally inserted central line that goes in the subclavian or the IJ, or into the jugular. Indications for ulcerative colitis or significant bowel obstruction. I have seen TPN given on patients with acute or acute pancreatitis when they are getting so malnourished also. Sterile technique and preparation during insertion and all maintenance anytime you're changing out bags, tubing, central line thing anytime, because there's such a high glucose content in this that there's a high infection rate. You need to monitor their glucose and their liver function tests. Your drug handbook, page 145C to 147C, goes over your parenteral nutrition. Where do I want you to focus? It's page 146C. Look at your disadvantages. No, let's see. No. Disadvantages over on the right-hand side of 146C. Risk for with insertion, use, maintenance of lines is where I said you have to be very careful with infection. So 147C on your monitoring, you will have a policy wherever you are working that talks about TPN, talks about monitoring. They have actual written orders. So TPN is managed by the healthcare provider, the dietitian at the hospital, and the pharmacist. Often the physician or provider will have TPN per pharmacy and dietitian. So they'll do, pharmacy and dietitian will do a whole evaluation and calculate all the vitamins, everything that goes in. They'll be ordering the labs, monitoring the labs, changing the TPN each day. Because the high glucose, the whole bag and tubing is thrown away every 24 hours, whether there's stuff left in the bag or not. It has that yellow color because of all the vitamins. You may have your lipids as a separate that you will infuse. That's every 12 hours. You change out the tubing and everything on your lipids. Usually they're ordered that you give one bottle of lipids every 24 hours. Then sometimes your lipids are in the bag. You may have a bag that is without the lipids and your next bag has the lipids because it's 12 hours on your lipids. So on your 147C in your drug handbook, it has you monitoring your CBC platelets, clotting times, your main things here. Those will all be ordered, all your liver enzymes, your proteins, your amylase, everything in your complete metabolic panel, which covers 23 things of your labs. Go to your down here to your daily, some nursing actions or daily weights, monitoring your vital signs, especially your temperature, your serum electrolytes, which is your potassium, sodium, chloride, and glucose, your BUN, which is your kidney function. I would not worry about the 2 times a 3 or weekly things. Those are all your panels that should be monitored per pharmacy or dietitian. Just that they're monitoring your fat content, triglycerides, and all those things also. Complications in the middle of page 147C, malfunction of the IV delivery system. because there's such a high glucose content. If for any reason you have to stop this TPN, if your next bag's not there, you have to hang D50 or high concentration of glucose, or D10, 10% dextrose rather than 5%. You have to hang that because the glucose content, they will have significant hypoglycemia if you don't. Sometimes you will be adding, when they're on a TPN or parental nutrition, you will be having them on a glucose or a sliding scale, insulin coverage, or adding insulin maybe actually in your bags. You will have a patient ask you, I'm not diabetic, why am I getting insulin? It's just because these high concentrations. Okay, so TPN should not be used routinely in patients with an intact GI tract because of possible complications by giving IV nutrition. Embolism can occur when air is permitted to enter into this closed system during tubing changes and when a new bottle or bag of hyperalimentation is hung. Complication can be prevented by instructing the client to perform the Valsalva maneuver. That's where they bear down when you change the tubing, change the line, do anything with it. You change it rapidly using sterile technique, using sterile gloves on your hands, cleaning your insertion sites and your connection sites. Signs and symptoms of embolism, very important for you to know, include dyspnea, shortness of breath, coughing, chest pain, and respiratory distress. Total parental nutrition feedings are refrigerated until they're ready to hang. Strict sterile asepsis is used. I mentioned the regular insulin being added to your TPN to lower your risk of hyperglycemia. Anytime this closed system is opened, when you're changing the tubing, changing the bag, have the patient do the Valsalva and always assess, do as quickly as possible, and assess for any air emboli. Your tubing is changed every 24 hours. Your dressing should be changed every 24 hours, initially starting this, and then you have to look at the policy for your facility. Parental nutrition complications. I put a slide for you here. Volume overload, especially watching your rate. Hyperglycemia, which I talked about. Hepatic complications, again because of the fat content, or maybe your enzymes. Cholelithiasis, which because of this you can have your gallbladder stones form, embolism, which I just talked about, and adverse effects of lipid emulsions. They can have complications, sometimes due to giving the little bottle of the fats, the white bottle of lipids. So you have to be careful in the rate you're giving it, and again, watching for a fat emboli. I covered in your drug handbook just the places for you to focus on, and I think I gave it to you verbally. That is the last of, well, let's see. Lipid emulsions, temporary hyperlipidemia may occur, particularly in patients if they have kidney or liver failure. Usually don't need treatment. It should resolve on its own. Delayed adverse reactions for your lipid emulsions can include hepatomegaly, mild elevation of liver enzymes, splenomegaly, thrombocytopenia, and leukopenia. So if you know that, what would you think with monitoring labs? You're monitoring your AST, your ALT, your spleen. You're looking at clotting factors and PT, PTT. You're looking at your platelet count, so you're watching your CBC. Again, with your thrombocytopenia, you're looking at that, and your leukopenia, because you're looking at your CBC with your white blood count. That is everything you need to know for pharmacology for Module 4. Oh, I didn't realize I talked about this slide, but I didn't show it. Slide: dyspnea, cutaneous allergic reactions, nausea, headache, back pain, sweating, dizziness if they have a lipid emulsion complication. And that will be the end of Module 4 Pharmacology.